Good evening and welcome back to this session that we are calling the Health from the Heart series. It's a series of conversations that we have with experts from different medical disciplines and where we look to align different disciplines of medicine and sort of demystify the processes of medicine for peers as well as for the general public. In this particular talk, in this particular conversation, we are going to focus on one of the major priorities in India, diabetes mellitus. And it is a major public health and clinical problem in India, and an estimated millions of people, close to 60 million, 70 million people in India have got diabetes and have some form of its complications running through. So it's a major problem. And for today's discussion, we have a very renowned, senior, well-experienced endocrinologist, Professor of Endocrinology, Dr. MV Muraleedharan from Thrissur, Kerala, who has nearly 5 years of experience in clinical medicine and endocrinology and is practicing at Thrissur, Kerala. Dr. Muraleedharan completed his DM in endocrinology from the PGI Chandigarh, Postgraduate Medical Institute Chandigarh, and is a member of the Royal College of Physicians, UK. He has been on the editorial board as a member of the Indian Journal of Endocrinology and Metabolism. And he has had a stellar teaching career where he has mentored and given direction to many physicians who are now practicing all over the world. So welcome, Dr. Muraleedharan, and we hope to learn from your wisdom and experience in this conversation.
Thank you.
Thank you. Our co-panelist is Dr. Rijo Mathew Choorakuttil, who is a radiologist with a special passion for fetal radiology and has been one of the founder members who has conceived a program that aims to address perinatal mortality in India through the integration of Dopplers with routine antenatal scans, a program known as Samrakshan. The program is running in 15 states, 40 districts, and is expanding throughout India and has shown tremendous results in the reduction of perinatal mortality, just through the introduction of fetal Dopplers and integrating that with the routine antenatal scans. And the program has brought about a reduction in perinatal mortality from about 30 that was reported for India to 17, and a neonatal mortality rate that is now ranging around 9. And this is when we are combining data from states like Madhya Pradesh, Uttar Pradesh, Rajasthan, Maharashtra, and a lot of the northern states, as well as other states, central Indian, southern Indian states, where perinatal mortality and neonatal mortality has been a big problem. So welcome to the show, Dr. Rijo Mathew Choorakuttil. To start the conversation, I'll start with Dr. Muraleedharan, and it's only fair that we start with looking at his experience as a clinician, an experience that spanned nearly 5 decades. How have you seen the field of diabetes change from when you started in the early 1970s to now, in terms of both clinical care, in terms of research, and in terms of the integration of research with clinical care?
In fact, the diabetes is a field that is changing rapidly in all the spheres that you have mentioned. For example, the number of cases are increasing on geometric proportion, especially in India. So from what we used to see in a few people, once upon a time, in fact, I started my job as a clinician in 1969. Now it is almost 53 years since I have been in the practice. Find that the number of cases are increasing. There are many reasons why why there is such a increase, a marked increase in the number of cases. There are better techniques for making a diagnosis. In fact, there is almost every household in, say, Kerala, or at least 1 in 2 households, have a glucometer. Whereas when I was a student, the places where a blood sugar could be estimated was far and few in between. Take the whole state of Kerala, maybe at 4 places: Kozhikode, Trivandrum, Ernakulam, maybe one more. That's all. So the diagnosis now is very easy because doing a blood sugar is now very easy. That the second reason, if to repeated information that is given to the public, people are more aware of the disease. That this is a disease you cannot play with. You have to take it seriously and do the right thing at the right time to avoid some of the complications. Diabetes, as such, is a disease without symptoms. The moment the patient develops a symptom, that means he has already gone in for a complication. Now at that time, some degree of damage, which may be irreversible or sometimes reversible, is done, and we can only partly put it back to the what it was before the onset of the complication. Thirdly, in the complication wise, we are able to diagnose these things much earlier. For example, a person with diabetes, he developed, say, microalbuminuria as another complication. Very small amount of urine which is not picked up by the routine urine albumin test that we are doing. It is an indication that this man has a risk for developing a cardiac disease and also renal disease sooner or later unless it is controlled very well. So you can predict it. Similarly, in the field of eye, routine ophthalmoscopy is recommended. At the time of diagnosis in type 2 diabetes and 5 years after the onset in type 1 diabetes, and is done as an annual show normally, but more frequently if there are evidences of retinal abnormality detected. And the level to which you go depends upon the type of institution or the doctor you are going. You may simply do a fundus examination, or you do a fluorescent angiography, you may do a retinal photography, and now we have got so many imaging methods that are available in the retina, like OCT. All those things have become much more precise, sensitive method by which you can diagnose the complication much ahead of the before the patient says, "Where I have got some problem with my vision." You see, and all the complications, all the segments of the eye, starting from cornea to the retina, they are all affected as a part of diabetes. Same thing true with kidney nephropathy at all stages. There is a involvement, and you have got methods of diagnosing early nephropathy by albuminuria and start the treatment with drugs. And we have got better drugs. That is the third level, that is availability of treatment options. We have got better drugs available which addresses each specific issues. Now diabetes is not just considered a metabolic disorder. It has got impact on the various systems like cardiovascular, renal, retinal, neural, every part of the body it is affected. And some of these complications, for example, cardiac problems, if you take, you can more effectively treat a diabetic with a cardiac problem with the newer anti-diabetic drugs like SGLT2 inhibitors, which is something which will act on preventing the absorption of glucose from the urine. It simply brings down the blood sugar, and it has got a cardiac benefit which is coming out of that. Similarly, the new DPP4 inhibitors, that also has got a cardiac friendly for this thing. And now it has gone to the extent that the FDA of USA, if they have to accept a new anti-diabetic drug, they have to show cardiac friendliness before it is being permitted as a diabetic drug. Similarly, in diabetes, the newer developments include monitoring the glucose control, starting from examination of the urine, which was the only technique available when we were a student. Then it came blood sugar estimation by the older methods. Now we have got more specific blood sugar estimation. The epoch-making discovery is a glucometer, and even that, there it has not stopped. We have got continuous blood glucose monitoring. You take blood sample every 5 minutes and analyze it over a period of 3 days and plot it out, and a computerized man it will say what is the level of your blood glucose fluctuation that has been occurring in the previous few days' time. So, in the investigation, they have also further changes that they have shown on that. For example, time in range or TIR. How many hours of the day the patient spend in the specified blood glucose level? The blood glucose level which is specified is between 70 and 160. There are people who will be going above that level, 160, below that level. So you calculate how many hours you are spending. It is called a time in range. And they have plotted time in range 10%, 20%, 70%, 90%. There is a proportionate reduction in all the complications of diabetes, renal, retinal, cardiac, neural, everything. If the time in range is more, you are better protected from these complications as well. And now we know that diabetes to an extent is a lifestyle disease. Lot of emphasis is now given a regular controlled diet for a diabetes. It always doesn't mean that it is a frugal diet. For a lean diabetic, you go give more food. Whereas an obese diabetes, you cut down the quantity of food. Similarly, regular exercise every day, a reasonable amount of exercise is a part of the daily requirement of an individual. And the importance of comorbid conditions are also coming in the picture. If you have got a diabetes, if you have to get the full benefit, you have to treat the blood pressure which is associated with that. Because diabetes patient has more chance of developing hypertension. You have to treat the cholesterol levels because diabetes and hypercholesterolemia, they are first cousins. So you have to treat the cholesterol part of it. Similarly, if you have to treat the comorbid conditions, then you get a better outcome in the long run. So I have just tried to give a broad view of what is being done. You can further take it up if you have got another question.
So, taking up from what you just discussed on the clinical aspects of diabetes, how does this information, if I can say, overflux or the rapid change in information, how does that translate into the education field? As an educator, how do you see it translating into the education system?
There
Are the
is
physicians
there,
trained? Yeah.
yes, there is some benefit. I won't say you get it because people, you must understand, type 1 diabetes, of course, it's a different issue altogether. They are symptomatic, they are in a difficult situation, and even to the extent that they may die if you are not properly treated. They take many of your education or whatever material you pass on to them a little more seriously than the type 2, which is a asymptomatic disease until complications starts in. In that case, it is extremely difficult to convince them as regard to the you have to take a regular exercise, you have to cut down these things from your diet, all those things. You have to check your blood sugar at a regular interval. You have to see the doctor periodically for assessment. You must consult a nutritionist for regarding your nutrition, or you must have an eye check. These things, if you tell them, many of them they don't take it that seriously. That is not only in India, that is the state of affairs anywhere in the world. Even if you go to USA or UK or some of those places where medicine is supposed to have advanced much better than say what is in India, but we find the complaints and the outcome even in places like USA is not far better than what you are getting in India. There is some benefit. Some people listen. Of course, the media has got a more role to play in these things. For example, they are interested in showing flashy things. For example, the cardiac surgery, or how you will take a stone from the gallbladder by using a this thing. That is what the media will show you in the television program. But that is not what is needed. A common disease, for example, which affects approximately 20% of the Indian population, with a 135 crores of people, 20% means 27 crores of diabetes are there. And if you consider the diabetic proportion of these, 97% are type 2 diabetes. Majority of them have no symptom, or they may develop symptom over the period. We have a role in educating these people. And one of the things which people are always fond of is the television. What percentage of time is actually earmarked for a disease like diabetes compared to treatment of cancer or HIV or anything? People who have got diabetes is much more than cancer or HIV or many of the traffic accidents or some of the rare procedures that they are showing. So they may probably, it will be more thrilling to see them. But as regard the utility is concerned, a proper, say, how will you manage your diabetes with regard to your diet? What are the diets which is permissible? What do you mean by a diet? How the doctor reaches the diet advice? All those things, or how frequently you should. Those things have to be emphasized in the media. Of course, every consultation, many people consider it is just to examine the pulse, blood pressure, and all those things. There's a couple of words to them, and then write a prescription and send the patient home. No, that is not the job of a doctor. His job will be every consultation is a teaching session where you have to tell the patient what you have been before, what achievement that you have made, and what you can improve on what you have achieved. For example, how much more exercise that you have to do, or how much reduction in your diabetes you have to do, what change in your food that you are supposed to make. It should be a teaching session. It is not simply a consultation. Is not a prescription session. It is a teaching session. This is how I would look at it, and this is how I may be able to answer. But there are many diabetes who are being treated by the pharmacies. There is something which you have to. No, I'm not joking. It's the truth.
Yes.
And very often they get advice from their relatives or friend. See, in the what they do there, they say, "Iniki under diabetes, nee idana kalichu onka." See,
Yes.
this is what they are
Yes.
saying. They may not come and see a doctor. See, what is fit for one person may not be fit for another person, because each individual is different. So, yeah, we can definitely improve on what we are doing. But there is some progress over what we started 50 years or 75 years ago.
I think that's a very important point. The point of educating the patient and communicating, and that each session has to be a teaching session. Each clinical session has to be a teaching session, and it has to be customized to the patient sitting in front of you.
Yeah. Yeah.
It cannot be a one shoe size fits all, and then whatever is good for everyone is good for you, and just do that. And it's not a cursory thing. And that is important because of the nature of multi-system involvement in diabetes and its potential for complications.
I will tell you one example to make it a little more better. Very often we get a diet which has been prescribed in our textbooks or some of the Western literature and all those things. That is not something which we can tell our diabetic patient to do. They have got an entirely different dietary pattern. What is the dietary pattern of Kerala is not what is happened in Punjab.
Exactly.
You have to understand, or in Calcutta.
Yes.
So if you have a Kerala pattern, you must know what is the normal Kerala food.
Exactly.
And what you are telling your patient should minimally differ from the normal diet of a Kerala man. Very minimal. Because restricting a diet is one of the most difficult things a person can tolerate. The food is the basis of life. You cannot restrict, and people may not listen to you. So you have to know. And food practices are different. I've seen my diabetes coming, doctor, can I take oats? The reason is there is advertisement. If you take oats, your diabetes sugar will come down, your cholesterol will come down, everything. What is oats? It is a cereal which is consumed by the Westerner as their food, staple diet. And it doesn't have any medicinal property. And this is what is thrown in the television, that you take oats, your diabetes will become better, your cholesterol will come down. This is the thing. So you have to, when a patient asks me, shall I take oats and I'll get benefit? I tell them, there is no harm in taking oats, but you don't start it if that is not your normal dietary material in your home.
Exactly.
Don't buy oats for this thing, because for that you can take one more blood test or take medicines a little more efficiently. That's what I tell them.
I think that's true. The nutritional advice has to be based on what is the normal nutritional pattern for that particular region.
Particular society.
particular society, and there is cultural implications there. There are financial implications there.
Yes.
There's a whole system of habits that has to be there, and we can't expect to break all of that
No, they
and then
won't.
suspend the process.
They won't. Even you
Yes,
tell them, they may do it for 3 days or 4 days, but they will come out
exactly.
of it. There is no harm in telling them. If you like something and you are told you cannot take this anymore, you will revolt. So they
Absolutely.
won't listen to you. Yeah.
Now, the another point you brought out quite clearly was that it is an asymptomatic condition, and by the time the symptoms appear, diabetes has been there for quite some time. In ophthalmology, we used to say that by the time retinopathy appears, what you call as mild retinopathy or early retinopathy, the person most probably has had diabetes for at least 10 years.
Yes, that's right. Correct.
And so what you think as early mild and starting treatment on early mild actually is not early mild. It's a decade long
Advanced. Yeah.
advanced stage.
Yeah. Yeah. See, therefore, what I would recommend that considering the incidence of diabetes in India, which is considered highest in the world, we are all at risk of developing diabetes. So, any Indian after the age of 35 must do an annual blood sugar checkup. Annual blood sugar checkup. It won't cost you more than 50 rupees or something less than that. You go to it. And if you do it to a government hospital, it will be done free. Okay? Annual blood sugar. If it is normal, he'll come next year on the same day, maybe next birthday, to check the blood sugar, give one more green signal at that time. But people who have high risk of developing, for example, strong family history, or people who are unusually obese, people who have got a sedentary habit, sitting in the office and working and not even getting up for taking a cup of coffee, or people who have developed diabetes during pregnancy, they are all called high risk people. In those people, you may start this testing blood sugar even 5 years earlier, maybe 30 years of age. Annual blood sugar, that's all that we are going to ask. Then, if the blood sugar is abnormal, they come under the group that they are diabetic people. Here again, the changes have occurred. As your first question, what changes have occurred? What was normal blood sugar or what was fasting blood sugar that was permitted when I was a student? It was 140 milligram. Okay. Then it was revised in 1973 to 126. Then now in the 2000s, 55 or 2006, it has been further revised to 110.
Yes.
What is the reason why it has come down from 140 to 110? They have found that when the blood sugar goes above 110 milligram, there is a steep rise in the incidence of complication. And they have recorded it with regard to retinopathy, because that is a place where you can see the vessel in life without difficulty.
Yes.
You can see a live vessel, you can see. So what they have told, it is important to start thinking of doing something, at least when your blood sugar is repeatedly above 110. Now they have they say 110 to 126, they call it as impaired fasting glucose. It's
Yes.
not normal glucose, impaired fasting glucose. After 126, you call it as diabetes. This is how the science have been progressing steadily. And what is the impact on the national economy? When you reduce the blood sugar from 140 to 110, many millions of people will come in the category of getting the treatment for the disease. So you are declaring them that you are diabetic. So in that case, there are many more people who will have to be, for them a medicine has to be provided. The follow-up facility should be available in terms of doctors, hospital, this thing. The complications have to be assessed. For example, if it is a foot care, diabetic foot care is very, very important area, because once your foot is damaged, you lose your livelihood. Then you don't have money to buy diabetes medicine. They don't have even money to buy the food. That is the situation. So regarding foot care, it has to be emphasized very carefully. And every diabetic visit to a clinic, at least once in 6 months, you must do a perfect clinical food care examination. Now you are not asking for gadgets. Now it has become a big business. They go to a diabetic center, so-called diabetic center. They have all these machines installed. 1, 2, 3, 4, 5. Okay. And patient go through all these things and sell out 2,000 or 3,000 rupees. And he doesn't have enough money to do a blood sugar after a month, fasting or postprandial blood sugar. You can do a clinical foot examination. Just see if the pulses are palpable, whether there is a hair loss, whether there is a loss of sweating, whether there is a sensory loss, are there any callosities, how is that foot arch? For example, you say hammer toe. That means there is some muscles are weak. That is why the toes are looking like a hammer. See, these things have to be done and the patient has to be told about it. So that way, we have definitely gone much better than what you are, but there is still a lot to go. That is what I would suggest.
What about pre-diabetes? The term pre-diabetes, how useful is that term? And you did tell right now that impaired glucose tolerance or the IGT segment also means that it causes an additional strain onto the healthcare system. We need the resources to follow them up, make sure that they're well managed and that they don't go into complications.
Yes.
How does pre-diabetes fit into this? Does that help with screening at an earlier stage?
It is another word that is used. That is a synonym actually. I told you that between 110 and 126, it is called impaired fasting glucose. Between 160 and 200, it is called impaired glucose tolerance. Okay. These are actually the pre-diabetic people.
Okay.
Okay. What will happen to them over a period? Either with intervention or without intervention. Intervention means they change their lifestyle. For example, they cut the food or regulate their food intake. They do regular physical activity. Two things can happen. This impaired fasting glucose will remain just like that, or impaired glucose tolerance will remain like that. At least you find a third of them will come back to normal. The glucose below become below than 110 or below 160. And a small number of people, it will go above the range. That is, they become much more frank diabetic from pre-diabetic. These are the, if the person is with the intervention or without intervention, if the person is able to remain stable or the blood glucose is touching back to normal, there is no reason to go with the drug in these people. For them, intense lifestyle intervention, which include at least 200 minutes of exercise every week, a diet which will take you to an ideal body weight. Suppose somebody weight at the time of visiting you is say 75 kilogram, and by calculation you find his ideal body weight is 65 kilogram, which means he is 10 kilogram overweight. So he has to target his weight, to attempt to reduce his weight to 65. Maybe he will not reach, but he must make an attempt. That is by regular diet restriction and regular exercise. You have to do it. So pre-diabetic means you observe them, and while observing, you give them intense lifestyle measures to control of sugar. And if you find they are going above, you treat them as diabetic. They are no more pre-diabetic. If they remain like that, a small percentage of people, you are saying that they are continuing to be, they need to be observed more carefully, which way they are turning, this side or that side. That if they remain normal, they come down to normal. Again, you have to say this is a person who might go in for trouble under ideal condition. This is how what is the pre-diabetes situation.
Now, how does we said earlier that there is a time period from the observation of a symptom in diabetes and from the onset. There's a time period, an interval in between. Now, in a case where diabetes occurs in a pregnant woman, gestational diabetes, usually the diagnosis is made around 26 to 28 weeks using an OGTT test. Do
we want to have the whole natural history of diabetes or only pregnancy and diabetes?
Gestational diabetes.
You have put two issues in one question.
Exactly.
Yeah. So one thing you have to understand, the diabetic metabolic abnormality is there at least 10 years before blood sugar has been found to be high. That is the time when you don't have blood sugar, but the metabolic abnormality is in the background, and he will develop diabetes complications. And it has been found that the fasting blood sugar rises earlier, postprandial blood sugar rises earlier than the fasting blood sugar
Yes.
in this situation. And that is after 10 years the person has been. And 10 is a good enough time for the patient to develop either cardiac problem or a retinal problem or a renal problem. So even on day 1, actually we are dealing with him on the 10th year of diabetic birthday. 10th
Yes.
diabetic birthday.
Yes.
So you have to take it very seriously. So then we go to the second part, that is pregnancy and diabetes. There are two people with pregnancy and diabetes. A person who is known to have diabetes become pregnant.
Yes.
That is totally a different situation from diabetes is detected for the first time in pregnancy. Okay.
Yes.
So what we ideally advise these people, as soon as a pregnancy is diagnosed, you do the blood sugar.
Okay.
You do the blood sugar. If you got three types of results will come. One is the person may have a normal blood sugar. There is one. He may have an impaired fasting glucose or an impaired glucose tolerance test. And thirdly, he may have a frank diabetes. That lady may have any one of these things. The approach will be very different. In pregnancy, the normal levels are also less. If your fasting blood sugar is 110, what I told you earlier, in a pregnant lady, it is 95. Because the fetus is continuously extracting glucose from the maternal blood. So for the pregnancy, it is a much more stringent control that is needed for that purpose. So once a patient comes with pregnancy, don't hesitate to do a blood sugar. Do it. Don't wait for 24 weeks or 26 weeks. Because 24-26 weeks is usually taken because that is the time very often the diabetes manifests in a person who is susceptible to become diabetes. That is why 24-26 weeks. But you don't have to wait till that time, because by 24 to 26 weeks, lot of changes would have happened in the fetus. For example, a diabetic environment is lethal to the embryo, diabetic embryo, which result in death or loss of the pregnancy. Then, as you go across the pregnancy, you have got organs developing one after another. At that time, if the blood glucose is not properly controlled, you will see dysfunction of one or more organs just coming. Classical one that has been described is the neural tube defect, and you can make it out by measuring the alpha beta protein in the lady. You see, so organs will be distinct. So if you have missed the opportunity to diagnose it on day 1, by 26 weeks, lot of organ damage have occurred in these people. After 26 weeks, what happens in the fetus? You must understand. The first part of it, you can say, the first 4 weeks is the embryogenesis. 4 to 12 weeks is actually organogenesis. Okay. After 12 weeks, if you go, you can find it is only growth of the fetus. By 12 weeks, you already have a fetus. Only thing is, its proportion may not be like that of an adult, but it has got every part of an adult, every organ that is present in the adult. You see? After that, it is only growth. So by interfering at that time, all that you can do, you can reduce the fetal macrosomia, but you will not be able to tackle some of the teratogenic effect of the diabetic milieu. So I would suggest any dietitian, especially of the Indian origin, we are a high risk patient as regard to metabolic abnormalities are concerned. There is no doubt about it. Proven. They have shown even for the same body mass index,
Yes.
Indians will have 2 or 3 times the visceral fat than a Caucasian person.
Yes.
This has been done by two people. There is a person called Yudkin from Scotland, and there is one called Yajinik from Pune.
Yes, Pune.
It is called YY hypothesis.
Yes,
Yajinik Yudkin hypothesis.
yes,
Found both of them has got the same BMI. Okay, but if you take the MRI of this person, Yajinik has 2 to 3 times the amount of visceral fat than Yudkin. See,
yes,
so that means the Indian group or a race has got a higher risk of developing diabetes. So pregnancy is a diabetogenic state. You must understand, even a normal pregnancy is a diabetogenic state. Why? Because only if the mother has got excess glucose present in the system, it will be transferred to the fetus for its growth. Nature has designed it as a part of it. But when it goes out of control, we call it as diabetes. That is how you have to understand. So I would suggest first appearance in the antenatal clinic, do a blood sugar. Maybe repeat it after 24 or 26 weeks
26 weeks.
to confirm it. Or if a person comes in one of the risk factor group, maybe you are doing it once or twice in that period between first antenatal review and 24 or 26 weeks.
Which brings me to, I'll involve Dr. Rijo in the conversation here. What are the imaging modalities that can be used, and what do you look for when you look at a pregnant woman with diabetes, a gestational diabetes?
So thank you, Praveen. Before I start answering your question, I think this is a great opportunity to have a Guru Vandanam to Muraleedharan sir. Both of us are his students, and I've been listening to sir that the logical sequences at which he was answering that the sequence of events, the pathophysiology being explained in a nice way, even during our MBBS times, and even now, sir's teaching is there is a lot of things to learn from it. Right now, I'm extremely. I've noted one particular point that sir has already highlighted. There needs to be a screening for blood sugar right from the beginning, and what is currently practiced among most of the obstetricians is to do an oral glucose tolerance test as 26 to 28 weeks. By that time, most of the complications have appeared, and we are seeing a baby and mother at risk, in the sense, because if you look at in the Samrakshan protocol, in the Samrakshan, when we prepared the document for Samrakshan, we in the current statistics in India, we have got nearly 6 lakh stillbirths. So in that 6 lakh stillbirths, how can we reduce the incidence of stillbirths? One of the major reasons that we come across, apart from the preeclampsia, preterm births, and the prematurity and all those things, is gestational diabetes being a major contributing factor for stillbirths, and especially from the imaging perspective. Especially when it goes beyond the 32 weeks or beyond in the third trimester, it's literally difficult for us to assess. Of course, macrosomia can be assessed, but when it goes into the different adaptative sequences that the fetus undergoes in a state of hypoxia, whether it is an adaptation in terms, with the help of color Doppler, we may be able to look into the adaptative processes of a brain sparing effect and stuff like that. But beyond that, in a diabetic metabolic acidosis status, we have no imaging markers or imaging tools to detect the problems caused in that kind of an environment, acidotic environment, especially only the biophysical profile, and that too at a very late stage, because the brainstem effects of all these things cannot be easily monitored with imaging, and that is one of the reasons why we lose babies even at the last stages itself. So that's why there needs to be a paradigm shift in the approach towards gestational diabetes. Maybe in the what Muraleedharan sir rightly said, we have to start right from the beginning, at the stage itself, right from the beginning of pregnancy itself, to screen and understand, because most of the structural anomalies, of course, we may be able to pick it up from the diagnostic point of view, maybe a neural spina bifida or an anencephaly or some of the structural defects in relation to organs or systems, we may be able to pick it up. But then by that time, most of the damage has already happened. It's just a management part changes actually. So what I wanted to highlight here is, especially on the gestational diabetes, what Muraleedharan sir has advised, there needs to be a paradigm shift which has to be really translated into the practice, which is not happening. The points that Muraleedharan sir had highlighted here, I don't think that the current practices in obstetrics and gynecology as far as gestational diabetes are concerned. Praveen, what do you think from our experience in the Samrakshan process?
Well, there is an estimation of blood sugar at the first visit. How far does that estimation of blood sugar be carried forward into clinical practice varies. Some people look at it with a critical eye, some people look at it with importance, some people look at it as one of the list of diagnostic tests that you mark without really looking at it. And most people tend to rely on the OGTT at 24 to 26 or 26 to 28 weeks. And within an Indian setting, it might even extend to 30 weeks or 32 weeks by the time the OGTT is done. At that stage, my concern has always been that we are already late. And the window that we have to now do something with the fetus is shortened considerably. Is there a way that we can start early? Like we started early with preeclampsia. We are looking now at the 11 to 13 weeks. We are looking at an algorithm. We are estimating a risk and we are starting low dose aspirin at that particular point of time. Is there something we can do like that with gestational diabetes? One study that we are starting now, that we have started to look at, is to look at the role of the fetal abdominal circumference. Again, it builds from what Dr. Yaknik has also done, where he is looking at the visceral fat and he is looking at the fetal abdomen, and he has proven that there is a difference and there is an incremental risk for our fetus. That carries over into adult life and that increases our risk for metabolic diseases. That's a proven fact, and he's measured that. And so, should we look at fetal abdominal circumference in the second trimester? Should we look at fetal abdominal circumference in the first trimester along with the blood sugar? And then we say that, well, can some of this, is there a cutoff value of the fetal abdominal circumference that can say that this woman is at a high risk for gestational diabetes? Do your blood sugar at the first visit, but don't wait till 26 weeks, don't wait till 30 weeks, don't wait till 24 weeks. Try to monitor earlier in between. Is that a possibility? The second thing that I have always wondered is how does the physiological changes in pregnancy, in the pregnant woman, how does the physiological changes alter once diabetes sets in? At the third trimester, as Dr. Rijo was saying, that we look at fetal hypoxia, but for a fetus in a pregnant woman with diabetes, hypoxia is not the primary concern. The primary concern is acidosis in terms of stillbirth. And at that stage, Doppler or the brain stirring effects does not help so much. And we are having to rely on the biophysical scores and other measures, which are good, but not yet optimized for use in our population. We have data that comes in from the Western population and we have those cutoffs, but we are not yet optimized it for our population. And if we look at, again, the body mass index, Dr. Yaknik's study apart, if you look at the adult body mass index, we have seen that 23.1 increases the risk as opposed to the normal overweight cutoff of 25 for the adult population, in a Caucasian population. So we are seeing that for us, the risk parameters are different. For us, the cutoffs are different. So the question is, we have a short period where the fetus is there and the embryo has set in, the organogenesis and the organ development is starting. At that point, later than that, we are only looking mainly at the fetal environment. We are looking at the fetal growth and we are looking to see how we can optimize childbirth without it leading to an intrauterine fetal demise or a stillbirth. Can that process happen earlier? Is a question. Dr. Muraleedharan.
Regarding the management of diabetes and pregnancy, changes have occurred in that area also. For example, instead of doing an OGTT, which is a cumbersome process, patient has to come fasting to the laboratory and then drink 50 grams of glucose or 75 according to the protocol that person is following, and go on collecting blood at 1 hour, 2 hour, and sometimes 3 hours. There are different protocols that are available. This has been simplified. What is called as a glucose challenge test. At any time you walk into the clinic, it may be morning, noon, evening, or night. Forget about what you have eaten or what is your food and when it was taken. They administer them 50 grams of glucose and take the blood sugar at 60 minutes time. And the cutoff point is 140. If the value exceeds 140, they are earmarked for a full oral glucose tolerance test. So if you have got, say, 100 people, if you do a GCT or glucose challenge test, people will need a glucose tolerance test, full GTT. You know, it is not a pleasant thing for a pregnant lady to drink 50% glucose, 100 ml. They will vomit most probably. So you can just give this 50 gram glucose and then take one blood sample, irrespective of the time of the day. We'll earmark the people for full OGTT, which can be done. So that way, the load can be taken down from this thing. Okay. But once you have a person with diabetes, irrespective of what you are going to do, whether it is a drugs or insulin or whatever you are taking, my personal experience, I use the glucometer very proficiently. In a normal pregnancy, I do a blood sugar profile, which is actually a profile for a day will be a 6-point. A fasting, pre-lunch and pre-dinner, a post-breakfast, post-lunch and post-dinner. It will be a 6-point to start. If nobody will be happy to do it every day, I will tell you, even if you have got glucometer, to prick 6 times on the body is not a pleasurable thing. What I tell them, one day you do it before food, 3 before food. The next day you do the after food measurement. Okay, and do it one time in a week. So that when they come for the review 1 month later, they have got 4 sets of results. Okay, that is 24 blood glucose levels at fasting and post-prandial level.
Yes.
From that, you may be able to identify what type of fluctuations that this lady is having with her diabetes in pregnancy, and which are the points at which there is a issue, and how you can tailor your treatment, whether it is insulin or OHA or whatever, so that these fluctuations can be decreased. Here again, a high-risk pregnancy, repeat of fetal loss in previous pregnancy. I may even go one step ahead to what is called as a continuous glucose monitoring system for these people. I may do it in every trimester. I'll do it in the first trimester. It costs you around 3,000 rupees plus. I'll do it again in the second trimester and then in the third trimester, from which I can know what is the type of fluctuation and what is its relationship to the food and activity and all those things. This is what I will do. And I tailor the medication according to the fluctuation that you are doing. So that I have my patients, at least a good percentage of them, they go through the pregnancy in a reasonable level of glucose levels throughout it. This is what I do.
When we look at control of glucose, is it a strict range within which the blood sugars must remain?
I told you the time in range. Time in range, which I told earlier, that is fixed between 70 and 160.
Okay.
And you, in a pregnant lady, I would recommend that a lady should be within the range at least 70% of the day. That means if you take 24 hours, 70% will be working out to around 16.8 hours. Okay. At least that much of time, the lady must have a blood sugar between 170 and 160. It is impossible with whatever medicine you are doing, except you use a glucose insulin pump, except that it is impossible to control the blood sugar every minute of the 24 hours. It is not possible. And it is not also practical to put a pump for all people.
Yes.
So we have to live what is practical and what is optimal.
Yes.
This is what we do. Okay.
Now again, Dr. Rijo, one of the other initiatives that you are now starting is looking at the fatty liver. And again, you're looking at it from the perspective of lifestyle modifications. You're looking at it from the perspective of how diabetes has added or has played a role in the, if we can call it, an epidemic of fatty liver as well in India. And you're looking at lifestyle modifications, you're looking at exercise, you're looking at changes that can help arrest it or regress it to a certain extent. What's your experience with imaging modalities in fatty liver, and where do you see this playing out?
Today happens to be the World Liver Day. So, as part of, I think this conversation has got a lot of significance, and the question that Praveen has asked. In the Indian Radiological and Imaging Association has started a new wing called as Preventive Radiology. The Preventive Radiology is primarily focusing on imaging biomarkers, and with the help of imaging biomarkers, we would like to stratify the risk of the population with respect to one, the lifestyle diseases, especially the non-alcoholic fatty liver disease, which is an epidemic that is unfolding now. And the second one is a coronary artery disease, or endothelial dysfunction and coronary artery disease, the atherosclerotic coronary vascular disease. Then the multimodality imaging of cancers, and then the screening for imaging with imaging biomarkers for early detection of endocrine diseases. So these are the 4 areas that we are focusing in the preventive radiology. And the question that Praveen has asked right now is, we are looking for imaging biomarkers with respect to a non-alcoholic fatty liver disease, especially the role of, because for the last 25-30 years, ever since this ultrasound has been available with radiologists, we have been seeing quite a lot of fatty liver. And I remember even in the late 90s when I report fatty liver, even till 2010, I think most of the time the physicians or the gastroenterologists say that all these radiologists will say fatty liver, don't worry, nothing. They used to reassure the patients in such a way. But then suddenly the dimensions have changed. That non-alcoholic fatty liver contributing to 20 to 30% of the liver transplants now, even in a place like Cochin, it is contributing to 20 to 30%. Then even the Trivandrum study that has come out recently, with 49.8% of population having some kind of a manifestation of fatty liver disease, and that means 1 out of 2 is having fatty liver disease. So the dimensions of fatty liver, and it's really an epidemic that is really unfolding. And we thought with the help of imaging biomarkers, apart from grading the fatty liver, because fatty liver is so common now, which are the category of groups that are going for fibrosis and progression into cirrhosis. So liver elastography has been brought into this particular protocol, and then we are doing liver elastography. Liver elastography basically is to know the stiffness of the liver, and with the stiffness of liver, if it is beyond a progression, beyond a certain limit, we come to the conclusion of a compensated advanced liver disease. And most of the other findings of portal hypertension, all these things we may be able to evaluate with the help of ultrasound and color Doppler, and with other imaging modalities too. But there is a particular subset of people with fatty liver disease who are slowly progressing into the fibrosis and the kind of and cirrhosis, and that category has to be screened. And if that category can be properly guided for medical interventions as well as for lifestyle modifications, we have got a very good chance right now at this window of opportunity to reduce the incidence of progression of into cirrhosis. And later on, maybe if we miss this opportunity 20 years down the line, we'll have to skill enhance most of the surgeons with doing liver transplants. So that is the kind of so we are looking at this from the national perspective. In the radiologists, near 20,000 radiologists are being skill enhanced for this particular project. And we are doing a multi-centric study in 10 centers all over India, and basically focusing on this particular. It's a comparative evaluation of diagnostic effectiveness of FibroScan, that is the vibration controlled transient elastography, versus 2D shear wave elastography versus MR elastography, and biopsy in the possible cases. So that's the kind of a project that we are doing, and imaging biomarkers for risk stratification of population is the strategy behind it.
So one of the key takeaways that's coming from this particular conversation is that diabetes is a major public health problem. As a population, we have a high risk for this condition, and we have to, and it's not just a number, 73 million, 1 crore or whatever people having diabetes. It's not just a number, it's a large chunk of people who need care and who need support from the healthcare system. And that means resources, trained people, identifying complications, and also bringing care down to a pragmatic, practical level. We have techniques now that can help with early identification of the condition. We have techniques that can help with the early identification of complications. The question can be that, well, is it because you're identifying early that you're seeing such huge numbers? Is it just that because, as Dr. Muraleedharan sir rightly said, it was 140, it became 127, now it's coming 110. If the cutoff is becoming 110, the number of people who are identified as having the condition will increase. So is it just because of that we are seeing this increase? And we have evidence from India that, well, we have a possibly genetic predisposition. There's definitely a gene environmental interaction happening. There is changes in the body mass index. There are other changes that contribute to this. So it's not only a change in the diagnostic criteria or the ability to pick up. We have this problem. Dr. Yachnik's study that looked at the fetal abdominal circumference as well as the visceral fat in the fetus also points us to the issue of adult undernourishment and malnourishment. That is a chronic problem in our population across diverse settings, across different settings. One thing that, however, comes up there is that the prevalence of diabetes or the incidence of diabetes is markedly different in the urban population as opposed to the rural population, which again is mediated by rapid changes in the lifestyle factors. So there is an underlying risk, and there is an additional added stress or insult that's happening to the system due to rapid changes in terms of stressors, in terms of nutritional stressors, environmental stressors, as well as other factors. And the whole picture is changing very rapidly, which might explain why we have a big differential between the urban prevalence of diabetes and the rural prevalence of diabetes. Education is one way to go. We need to educate population. We need to have more programs that focus on conditions like diabetes, which are silent, last for a longer period of time, as opposed to, without saying that they're not important, but as Dr. Muraleedharan rightly says, as opposed to immediate interventions that look thrilling and that are done for cases that are rare, and that has a glam value around it, and that can attract people to the field of medicine. But the nut and bolts of medicine lies in that you have to treat people for a longer period of time, the basic conditions for a longer period of time, if it should not manifest into a more complicated state at a later period of time. We are seeing that with fatty liver. We are seeing that the progression to cirrhosis can happen. NAFLD can progress to cirrhosis. We are seeing that the possibility of hepatic transplants becoming widespread, a common procedure in the future, can occur if we don't take preventive steps now. What would your concluding message be for the audience on this topic, Dr. Muraleedharan?
We have fairly discussed a lot of things in this thing, and diabetes and metabolic syndromes are closely related. That is one thing you have to do. But in spite of that, you miss. I am a victim of that. For without knowing, I have a major problem like cirrhosis liver, which needed in a transplantation. Okay, I never knew that I had the disease, and I have no risk factors. Understand? I have never been an obese person. I never indulged in alcohol. Never took alcohol in my life. And I used to have regular exercise 1 hour from my younger days, from the school days onwards. Even today morning I had exercise 1 hour. Still, you are likely to miss. Don't put that it is the failure of the system. There are always some odd things which can occur. But the majority of the people, a timely diagnosis. For example, you get fatty liver, as Rijo has mentioned. Oh, every radiologist will write fatty liver as an associated thing. Like our pharmacology teachers say, for every disease side effect, nausea, anorexia, vomiting, like that. That used to be there. But if you see a fatty liver, at least why not we look a little more into it? For example, you do an enzyme, you will see his body proportions and everything. And if there is a problem, you go for a scan. For example, fibroscan is a real development in this area. Just fatty liver not alone. All fatty liver doesn't go in for cirrhosis. Only around 10% or something like goes for cirrhosis. Okay, you have to educate the people. And from our side as doctors, we should not leave anything unturned. If you have found a doubtful thing, please go ahead with that. But that will give you a clue and may probably make a person's life more comfortable in the future.
Dr. Rijo, concluding remarks from your side?
I think today's discussion with Muraleedharan sir and you have made me wiser. In the sense, it has made me more active and energetic to take up the projects that we're already doing, because there is few areas where I've been working apart from this fatty liver and gestational diabetes, and one more area that has got strong relation with is in the men's health and sexual medicine, erectile dysfunction, especially. We have been doing a lot of penile color Doppler studies for differentiating the arteriogenic causes and the venous leak. And we have been doing in our centers, we've been doing the penile implant surgeries, and we've been getting the cavernosal biopsies, especially in the diabetes patients, with the cavernosal biopsy correlation with this particular. So there is a significant amount of complications, and there is a window of opportunity to pick up these things, to screen this population and advise them or for lifestyle modification, or even have medical interventions at a very early stage. So screening strategy of screening the population or and to get the high risk group for an effective management has to be taken up in our country, because this is the numbers of most of these numbers of diabetes and the complications are really huge. So if we need to address it properly at this very early stage, we need to have a very different strategy, and that has to be put into use as a national screening protocols, or with the help of the health authorities, at the help of the health ministry and all the medical professionals converging together to have a uniform opinion, or to have a kind of a algorithm that has been raised for this particular problem. This is actually this is a real big epidemic that is unfolding. It's not after COVID. I think these are the things that we need to concentrate. So I think this discussion has been very fruitful and has given me a lot of new insights. Thanks to Muraleedharan sir, and thanks to you for initiating this discussion. Thank you.
Well, thank you, Dr. Muraleedharan sir, for a wonderful discussion and for sharing your experience and wisdom with us. Thank you, Dr. Rijo Mathew Choorakuttil, and I hope that we can invite you back for further discussions on diabetes and other related aspects, Dr. Muraleedharan sir. And with that, let me conclude today's session. So stay safe, be happy, check your blood sugars at least once a year. If you are above 30, if you are overweight or obese, make sure that you are doing it. Don't wait for a sign or symptom to come and visit you or knock on your door and say, hey, I am here. The guest has already been there 10 years earlier. You just didn't see it. You didn't clean your house well enough and you didn't notice it. He's been sitting there waiting for you. And by the time you notice and say, hey, what are you doing here? The damage is done. So get in early. Make sure you do your checkups early. It doesn't cost much. It's widely available. There's no excuse of saying, oh, it's a costly test. It's not available. It's available everywhere. You can get it done free. You can get it done at a very low cost. It doesn't take much time. It's a prick. Getting a small amount of blood out, getting the test done, easily done. So make sure you do that. Stay safe, stay happy, keep your blood sugars under control, and till we meet again, goodbye. Thank you so much.
Thank you. Thank you, sir. Thank you, sir.